Hello everyone, my name is Megan Jordan. I'm here to speak to you about the Fall Safety Care Bundle Measurement Grid and mid-shift huddle effects on high fall risk patients in the progressive care unit. Now let's get started. So we want to talk about right now the mid-gist of the project, which is the fall risk patients that are in an acute care setting. Now, first thing we kind of think about when setting up this project is what is our PICO question? And our PICO question is, do patients that are over age 18 in the progressive care unit who are identified as high fall risk, does the implementation of the fall safety care bundles measurement grid and mid-shift huddle as compared to the standard fall precautions decrease falls over 1 month? We're going to kind of get into inclusion criteria, exclusion criteria, and so on and forth with details as we go forward. Now, the background of this unit, it is a small unit located in the southeastern portion of the United States. And it specifically has about a 2 to 3 day turnover rate with their patients. The methods and interventions as discussed, we're going to be using the Fall Safety Care Bundle Measurement Grid, as well as the mid-shift huddle. Now, the Fall Safety Care Bundles Measurement Grid is distributed by the charge nurse when assignments are passed out at the beginning of the shift, and the are conducted by the floor nurse. Now, the mid-shift huddles are ran by the charge nurse in the middle of the shift, but it includes our exercise physiologists and our certified nursing assistants. And that kind of is for them to talk about any acute changes in the patient. Has there been a change in need of the intervention? Those individuals have much more hands-on opportunities to work with the patients than the nurses do. So this is a great way to get an overview of any sort of changes or impact that something would have on a patient's fall risk. Now, this project is considered as a quality improvement retrospective chart review or audit after the intervention's in place. And we'll get more into that as we go. Our results that we came up with had a positive effect on the patient's fall risk, and we'll talk a little bit more about that. But they did not significantly have enough positive effect to make a significant difference in the fall risk pre and post of the fall. But we'll get back into that. Let's move on. So the time frame of the quality improvement project, the data collection process, was between December 16th and January 16th. And this is important to note because this time frame does have such a impact or potential impact on the results that we did receive or analyze after collecting the data. So some are wondering, what is a fall care bundles measurement grid? The screen in front of you shows the tool that is used. At the top, you'll see that the nurse can put any sort of indication of what the patient's identifier is, a room number, initials, anything of that sort. It holds 20 patients' information on one sheet. So it's very quick. The nurse can go down, do checks, observe if the call light's in place, if any of the interventions are in place. Has there been any changes with their medication that might have an effect on their fall risk? Has has there been a fear of falling for the patient? And so the patient's scared and very rigid when walking. I mean, there's so many different scenarios that we could throw at this. But this does allow for the nurse to quickly address those things at the beginning of the shift. Now, if you notice, this is developed in the United Kingdom, and some of the verbiage is a little bit different. So if you notice at the top, they say ward, we call them nursing units or floors. So there's a little bit of difference in the verbiage that's on here, but the intention is still the same. We're trying to make sure that the fall interventions that were put in place on day one upon when they were identified as a high fall risk patient, are they still in place? So the goals of the project are to uh, decrease the fall rates on the progressive care unit for our high fall risk patients. The aims, we want to decrease the fall rate, increase the patient safety. We want to decrease hospital stays because if you have a fall with an injury, that could negatively impact the amount of days that the patient is in the hospital, as well as decrease healthcare costs and increase patient safety outcomes. So we kind of talked a little bit earlier about inclusion criteria and how we would get into it. So let's get into the inclusion criteria process. So with the inclusion criteria, we want to make sure that the patient is 18 years old and older. So no pediatric patients on this case, on this project. They need to be identified as a high fall risk. They also can be any gender or race. That does not impact the project itself. And they need to be admitted to the hospital on the progressive care unit while data collection is being conducted. So that's important. We don't want anybody prior to the collection time frame or after the collection time frame. We want to focus on that one time frame I gave earlier, which was December 16, 2022 to January 16, 2023. The exclusion criteria, if we have patients that are younger than the age of 18, patients that are not identified as high fall risk, and patients that were not admitted to the progressive care unit while the data collection process was going on between December 16, 2022 and January 16, 2023. Now let's talk about our method. How are we going to analyze this data that we collect? Sure, we implement interventions. Sure, we do the retrospective chart audit after the data has been collected. But what do we use to say analyze this data? We're going to do a z-test of two proportions because two interventions are put in place, not one. And it's important to be able to depict which intervention might have helped and which isn't, or maybe both help or both didn't. Later on in the project or presentation, you'll find that out. And then our outcome measures. What are we going to do with the data? What are we going to do with the statistical information that we find? And we'll get more into that as we go. Now, when we're setting up a project of this sort, we want to definitely do a literature review. We want to find what's out there. We can't just pull anything out of the air to put into place. We need to find something that has been vetted by multiple sources of information in regards to, is the intervention successful? So the search terms we used were FallSafety care bundles, acute care falls, Huddle progressive care falls, Huddle patient safety. And if you notice, we're mixing some words in there, Huddle or falls or acute care or bundles, to try to get a broad spectrum look at what is out there on the research theme of what they found out about these subjects. Also, we talked about Huddle progressive care unit, fall prevention communication, because these are communication tools that we're putting into place. and the patient safety and fall safety care bundles. Now, granted, that's a lot of information to look up, a lot of subjects, search terms to look up, excuse me. The initial results came back with 17,100 articles. So we had to start narrowing down our search. I used the Maryville University Library and utilized the Cumulative Index of Nursing and Allied Health Literature, CINAHL, to narrow those, making sure that there are credible sources that we are looking at. Also, we wanted to implement filters and parameters such as timelines. We wanted recent articles. Our time range was from 2017 to 2021 at the time that the literature review was conducted. And then that resulted in 337 articles. So then when those articles were reviewed, final results that met our criteria, addressed our inclusion criteria, and addressed our interventions, it was narrowed down to 11 articles in the end. Now, how do we put this information into place? How do we get the change going? Well, this is where theoretical framework comes through. Lewin's force field analysis. This is an oldie but a goodie analysis. This is from 1951. Reference later in the presentation. First, we're going to unfreeze the process that is being done currently on the progressive care unit. So we're going to prepare for the implementation of the interventions. That means education of the staff. That means ensuring that the staff is aware of the fall policies that are already in place on the floor. And finding out what is going on. What is their true issue at that progressive care unit? Then we're going to, once we've kind of prepared things and we're ready to implement, we're going to staff educate again. There's never enough staff education. We're going to implement those interventions, the fall safety care bundle measurement grid, as well as the mid-shift huddle intervention. We're going to implement those. Then we're going to analyze the data. We're going to look at the the pre-fall rate interventions rate versus the post-intervention fall rate for that progressive care unit to analyze, did this really make a difference? Did these interventions really make a difference? Once we identify if they did or not, we're going to analyze what went right, what went wrong, what could we have done better next time? Once we identify those things, we're going to pick and choose what we think did great, and we're going to put those in place and freeze it. The staff has been engaged and notified and educated for those interventions that worked great. And it's kind of an interview of sorts to find out what processes would work for those patients and that floor, because every floor is different and every hospital organization is different as well. Now let's think about the timeline. It didn't just happen in December 16th through the January 16th. This project has been going on for quite a while. The needs assessment was identified when we discussed the CNO, the CEO, and the DNP community chair, as well as the PCU floor manager. What are their needs? And they identified their needs were fall rates needed to improve. They were having problems with fall rates with high fall risk patients on the PCU floor, excuse me. That happened within a week's time frame, August 10th through August 17th of 2021. It is not unusual for this to happen in such a short amount of time because the senior leadership was very well aware and ready to jump on this issue and try to make a difference in their patient's safety and their patient's outcome. Then the IRB approval came along. August 5th, 2022 to October 7th, 2022 was when the process of the IRB application was being put together, edited throughout the time, ensuring that all of the documentation was together in the correct order, and then submitting it to Maryville's IRB committee. Now, the approval came through on October 7th of 2022. So in the timeline, you would think that the interventions would be put into place closely to October 7th, but unfortunately, we did run into some barriers that we're going to get into and kind of explain why we have a gap in time there. We also had, so then we go to the December 16th when we educated the staff by presenting a presentation and implementing those interventions on that day. The staff is very, very familiar with mid-shift huddle, not in this sense, but huddles are used across the nation to increase communication between staff members. It just so happened we're using the huddle method to help with, hopefully, the fall rate on this floor. Then the results are looked at from January 16th, which was the last day of data collection, to February 14th of 2023. Data was collected and analyzed, data was collected between December 16th and January 16th. Then it was analyzed between January 16th and February 14th. To really understand, did we make a difference with these interventions? Now, results. Everybody's waiting for results. The p-value of the z-test of two proportions resulted out as a 0.7065. What does that mean? That means it did not make a statistical difference in the fall rate from pre-intervention fall rate on the PCU floor to post-intervention fall rate on the PCU floor. But that doesn't mean it didn't make a difference. We're going to move forward with this. Keep that in your mind for the next slide. Now, the pre-intervention fall rate was 2 falls for 634 patient days. Post-fall intervention rate was noted to be 1 fall for 609 patient days. Now, the sample size was 165 cases. Granted, there's only 1 fall difference in this, but technically it did make a positive difference in the fall rate on the PCU floor when you compare pre-intervention fall rates to post-intervention fall rates. Though it did make a difference there, it did not make enough difference to make a statistical significant difference in the fall rates on the PCU floor. So it's different to think about this. 2 different things. One, yes, it did make a difference, a good difference, but not enough to be significantly important. Now let's look at the analysis. Why did it not possibly make a significant difference in the fall rate after the interventions were put in place? One thing that was noticed was the FallSafety Care Bundle measurement grid completion rate was 55.75%. Only 95 patients were documented on as being completed with the fall bundle grid. Now with the mid-shift huddle, since that particular vehicle or vector was used for this intervention, the staff was very familiar and comfortable with it. So we got 100% compliance on that. Let's talk about what did that 55.75% possibly do to our results. It could have possibly negatively affected the statistical difference in the results. Now let's look at the time frame that this was done and the data was collected was during the holiday time. The holiday time, if you notice, the graph on the screen is a nurse compliance with interventions. Yes, we've already talked about this, but I really wanted to focus on, if you notice, the lack of compliance was really during holiday time, right after Christmas, and then right after New Year's. One, let's talk about that. Staffing shortage has been a huge issue for hospitals across the nation after the pandemic of COVID came. That's one. We're already struggling with that. Two, we're struggling. It's holiday time. People want to take their time off to be with their families. So staffing is negatively affected as well. Then you also have to think about where the location of the organization is at or the hospital is at. The acute care setting is located in the southeastern part of the United States, and that is a hot place for population to come from the northern part of the United States down to the southeastern region of the United States, what we like to call them as snowbirds. You probably have heard that term before. So with this influx of patients, it increases the ratio with staffing at a low because of holiday time and because of staffing crisis with retirement and the pandemic of the nurses that has occurred across the nation. So it's very important to remember while we're trying to digest this information and analysis. Let's talk about barriers, which we kind of already talked about just now. Holiday time, shortage of staffing, and the influx of northern temporary residents that occur every year. Now let's move on to the implications for nursing practice. The nursing practice, it increased their awareness. It was the fall bundle grid was a communication tool to increase awareness to the nurses to ensure that those interventions are remaining properly implemented like they're supposed to be. We've all had it where you go in as a nurse and you see a patient that's supposed to have fall interventions in place, and they have been removed or not put back into place like they should be after being seen by a doctor, an outside entity such as therapy. And that's important that these things are kept up on. The interventions do work, but they must remain in place. Now, high fall risk patient status. We need to ensure that no acute changes have occurred, and that is done by the mid-shift huddle. It also is addressed with the fall bundle grid, but when you're doing the fall bundle grid, it does address, has there been any medication changes with the patient? Have there been any falls? And this is checked every shift. So that's one address of the intervention. Also, the high fall risk status is also discussed in that mid-shift huddle. Those exercise physiologists and the certified nursing assistants have much more hands-on one-on-one time with the patient than the nurse does. So therefore, they're able to discuss with the charge nurse if there has been any acute changes in this patient's status. Has the patient come back from a procedure that has had sedative medication? We want to make sure that those acute status changes are caught as well. And it just strictly is a topic of conversation. Between the report of the nurses talking about the grid during report as they're doing room to room report, as well as the conversation in the mid-shift huddle. It incorporates multiple disciplines. Your nurses, your charge nurses, your CNAs, and your exercise physiologists are all doing at least one of those interventions. And the more exposure will increase the awareness of your high fall risk patients. Next, implication for future research. I would recommend a project champion be identified at the location. This not only helps with engagement and hopefully compliance of completing the interventions, but it also helps with identifying weaknesses within the staff to help address with education. Of course, we encourage additional education. And also, timing of the data collection. Maybe we would have had better results and had a significant positive difference on the fall rate, pre-fall rate, prior to the interventions versus post-fall rate after the interventions in place, if it was not done during the holiday time. And that's something the future researchers can look at as they're planning for this project. These are the references, and this is my contact information. Thanks for listening in. Hope you have a great day.